Hello, welcome back to Little Squirts, Big Problems. I'm John Payne, physical therapist.
And I'm Kellie Witten, physical therapist.
Awesome. And we're here again talking about more of the pelvic floor.
Yep.
I think I messed up last time. I said we're going to talk about the potty question. It's the potty puzzle.
Oh.
It's got many pieces. There's a lot of pieces to it. Everyone's got questions, but there's a lot of pieces to it. So we are trying to solve the potty puzzles. Today, as we talked about, we're going to dive in a little bit deeper into dysfunction. Maybe talk about what things could be going wrong and what's behind those and why or what we should be doing about it. So maybe you want to briefly just give a recap on like some anatomy real quick and just breeze over that.
Yep. So we talk about pelvic floor, or as I refer to it with a lot of the kiddos, is the potty muscles. So inside of our pelvis, which is kind of at the bottom of our trunk, like in between hips, bottom of the spine, all these bones come together to make our pelvis. Inside of that pelvis sits the pelvic floor. It's kind of like a hammock of muscles that provides support to our body, holds all our intestines, and then also right on top of it, bladder and bowel. So we're kind of what holds our pee, what holds our poop, and then it helps control when we go to the bathroom. So there's like tubes essentially that go through the pelvic floor. Urethra and anus that go through, and there's some sphincters around those that are little like bands of muscle, essentially circles of muscle, and those are closely linked into the pelvic floor. So that's what helps control when we go pee and when we go poop.
Right. So when everything's going good, we get to the bathroom when we need to. We sit down, we either pee or we poop. Right, and everything's good.
Yep.
We do our cleanup. And we go on about life.
Yep.
So tell me what can happen or what can go wrong specifically with the pelvic floor.
Yeah. So kind of the most typical things, I'd say number one thing you're seeing, whether it's super obvious or not, especially with kids, is constipation. So whether that's they're not going frequently enough, or when they do go, it's really hard. It's hard to get it out. A lot of times with the constipation, we'll see like withholding behaviors. So sometimes it's like, different body movements that they'll do. Sometimes it's actually like behaviors can be an indication that kids are like withholding and have this constipation.
Like a little dance, or like I know you got the pee-pee dance, right?
Yeah,
like
you've got that. A lot of times it's like, sometimes it's like, it's different for every kid. Sometimes it's like crossing the legs. Sometimes it's like just like really going rigid and squeezing really hard. Sometimes kids who have like, to dive a little deeper, sometimes kids who have like big emotional outbursts or other things like that, or significant behaviors, it will actually also be a sign of constipation type thing.
Okay.
That's something you kind of have to delve into deeper. It's not always obvious.
Yeah. This may be a little gross. Like, what does constipation look like?
So
often I don't look at my kids poop. I don't go in the bathroom after they're done. Like, don't flush.
Yep.
Because I need to look at it. Like, that only happens with nurses in the hospital. Like, they really care about the consistency, the color, and the frequency, and all that kind of stuff. And so what?
Yeah.
If I were to look in the toilet, like, I say, I'm just curious.
Yeah.
Like, what do my kids' poop look like? It's normal, not normal.
Yeah. So kind of there's a couple different things. So we talk about frequency. So that's how often are they going? Ideal is at least once a day. The second thing is there's a stool scale that basically has different like pictures of like the hardest stool to the softest stool. One is like the little hard rabbit pellets, all the way up to 7 is like liquid. And where we want to be typically is like a type 3 to 4. So soft, a lot of times they say like sausage, like should be easy to pass. We shouldn't have a lot of straining and pushing. It should be able to go pretty soon. You shouldn't have to sit on the toilet and sit there for 10 minutes to go to the bathroom. Like you should be able to sit and go. That's, yes, maybe you're distracted. You're not actually really working on it. You're distracted. Ideally, you should be able to just sit and go and get it out pretty easily and quickly. So with kids who are constipated, a lot of times we'll see less frequent. I have kids who are going like 7-10 days in between bowel movements.
Okay.
Yeah. Or it'll be really hard. They'll have like just tiny, small amounts. They'll never really have like one big full bowel movement. They just get like a little bit out at a time. So they're not really fully emptying.
Snack size.
Yeah. Yep. Pain, straining. So they're pushing really hard. And then it's hard because actually there are some kids who will have pretty consistent, like soft bowel movements, but they actually will still be constipated. And sometimes you don't know that unless they do like an x-ray. So they'll do an abdominal x-ray and they can see how much stool is backed up. in kids' bodies. But there's been studies that show I think it's 50% of kids who are having a daily bowel movement, if you did imaging, they would still show up as constipated, or that they'd have some stool retention, they'd have stool left over in their colon.
I mean, we're always going through, right?
Yeah.
I always feel like something's coming in, something's going out.
Yep.
So at any given time, you're going to have stool in your intestines, but it's when it's the train is
a certain amount is more backed up. Yeah. And they'll talk about stool burden, which is how much stool is in there. And usually they'll give it mild, moderate, severe is kind of what I've seen, how much is in there. And I don't know how they determine mild versus moderate versus severe, how far backed up it is.
Relative terms, right?
Yeah.
So, okay. Well, that's good to know. Then what about the urine side of things, the pee side of things? What does a dysfunction look like there?
Yeah. So it can be a couple different things. It could be pain with urination. It could be urgency. So having to run to make it to the bathroom on time, kind of having a delayed message to your body of you have to go, so that when it hits, you have to go right away. There's no you should ideally have a little bit of a warning, and then you can hold it and make it to the bathroom. Some kids, it's nope, when it hits, they have to go right away. If there's not a toilet right there, they're going to have a leak. They're going to lose their bladder.
No control. It just comes out.
Yeah. So there's that, or there's kind of surprise leaks. So it's they'll just be going about their day and they'll just leak whenever. Sometimes we'll see kind of more leaking with activity. So laughing, there's something called giggle incontinence. So when kids laugh, they'll lose the full bladder, and adults may experience this as well. Sometimes with kind of higher level activities, so running, jumping, that will be the only time they experience incontinence, but it's still showing that there's dysfunction in the pelvic floor. And then also bedwetting, especially prolonged bedwetting.
So what about, how does that look? When kids are really young, your infants, obviously there's no control. We do a lot of diapering and stuff. At what age do we expect some of these things to become more normalized, or where they do have control? Yeah,
so usually around 2 to 3. Every kid is different because it really is based on their development. So if you have kids who are maybe a little behind in their motor milestones, they walked late, they didn't crawl, or they crawled late, those sorts of things, that can delay potty training as well, because all of those things help build up the pelvic floor muscles. And so if they're behind on those things, we expect that toileting is going to be delayed. Also, toileting is so tied to there's so many things it's tied to. On the surface, we see this kid can go into the bathroom, pee or poop, just the basic toileting thing. Underneath the surface, there's all these things that have to come together for that to go well. So not only is it how strong are their muscles, it's also can they coordinate their muscles to be able to sit and relax? Can they sense when their body needs to go? Can they tolerate just sitting on the toilet and being off the ground? There's a sensory side to this of how does their body experience the world and take all that information in. That could all impact how it works.
And you mentioned relaxation. A lot of times you just think about muscles as contraction based. Am I not strong enough? But you're saying sometimes we need to have signals that will not contract.
To relax. Yep. So I would say a big thing that I see and have to work on is kind of both. I mean, because these kids who have pelvic floor dysfunction, especially when we're talking about constipation or holding, that pelvic floor muscle is kind of chronically or always turned on. And so it's the muscle's turned on. You would think it's strong, but it's just holding. It's not actually really working. It's just tight all the time.
Okay.
So it has to be able to move and stretch out like that. So when we go to the bathroom, we need things to relax and stretch out. But then they also do have to be able to turn on, for example, when I talked about the giggle incontinence or running and jumping, that puts a lot of pressure down onto that pelvic floor. So that hammock has to react against that downward pressure to hold continence. And so if we don't have that, things just kind of come out.
So it's like any other muscle. If I want to lift to get a glass of water, I have to extend my arm. I have to track my bicep just enough to bring it on up.
Exactly.
Then I go to set it back down. I just don't relax. I lower that down as controlled. I set it down. That movement's successful because of my ability to control my muscle contraction, intensity.
And you're moving through a range. You're moving through a movement. You're not just either here or here. Right. So it's not I'm either all the way on or all the way off. It's that grading and kind of in between movement.
And pelvic floor, you're inside a bowl. So there's very little movement per se going on. I mean, things are moving, but it's not a visual movement.
Yeah, and it's not like the arm where the arm in a lot of ways, or the legs, you're moving it in reaction or to like you said, to pick up a glass or something. The pelvic floor, because of where it is in our body, it always is reacting to what's happening because
It's at our center.
Exactly. So even when we're just sitting here doing nothing, like it has to respond to the pressures that come from like our breathing muscles, our diaphragm pushing down onto it. It's not like it can just,
it's not
doing nothing. Like it's got to always have a little bit of.
That's a great point, because I think about like the anchoring system, right?
Yeah.
Because for every action, there's an equal and opposite reaction. So if I'm going to act by moving my limbs against gravity, my base has to be stable enough to allow that to occur. And if it's not, well, you're saying like I could either fall over or I lose my bladder.
I
remember in college, there was a guy, comedian came on our senior night. He's like, all right, everybody, you're graduating. Everyone's going to be successful unless you can't hold your fart. It's just going to ruin a job interview. It's going to ruin everything for you. So I think that's true.
And it's pretty amazing. It's pretty amazing. Some kids will like look from the outside picture, they'll look like they're doing so well, but then it's like the pelvic floor, their base is not working well. And when you really dive into it, it's like, in some ways it's like, how is this kid presenting as they're doing so well, because this big part of their center is not working well. And the only symptoms end up being the bowel and bladder control.
And I've seen some kids, and this isn't my specialty, so that's why I love having you here so much, because I've seen some kids, I've been working on like elbows or something completely unrelated. And then you see like the top line of like a pull-up. And it's like, you're like in second grade. Like, why are you in a pull-up? And I'm sure mom and dad are just like, I don't even know what to do. But obviously I don't want them to be embarrassed at school. Like, this is a socially unacceptable thing. And so maybe you can touch on that. Like, what are like some maybe myths or things that are kind of surrounding like bedwetting or like that loss of control, or when they're not happening and you're just kind of like waiting?
I mean, I would say like, again, it's dependent on like what the kid's total development has looked like and if there's other things going on, but really like kids should be able to get control of and like potty train. Really, like 3 is pretty standard age. I would say 3 to 4.
Assuming everything's been
assuming everything is going well. If you're trying potty training and you've tried it a couple times and it's still like you're hitting those walls, or like sometimes I'll see kiddos who it's like they potty trained really well for one, so either pee or poop. Typically they do, what you see more often is like they'll get pee down, but they never really get poop. And so that's like kind of like a sign of like, okay, something's going on here. And then bedwetting really beyond the age of about 5. Again, that depends on when kids daytime train. So if they're later in their daytime bladder and bowel control, then they're probably going to be a little later at nighttime. But yeah, really like 5 or so, kids should be staying dry through the night. Sometimes up to 7 can be typical. The hard thing about nighttime is like there's other things that contribute to it. So it's not the same as daytime. There is a piece of like your bladder has to be big enough to store urine, and your muscles do have to be able to like, hold, but it's also like a hormone thing. So your body has to release hormones to tell your bladder to store urine. And that can be more of a genetic thing. So like if there's a family history of bedwetting, that makes people or kids more prone to having that. And so sometimes they will have more prolonged because it's a genetic thing, and that should improve over time. But I think even if you have a family history of that prolonged bedwetting, like there's so many other things we can look at to say, hey, is this contributing? So big thing that really contributes to prolonged bedwetting is constipation.
So tell me more about that, because I'm interested, because I think about them as 2 separate entities. I urinate, I poo, right? But you're saying like there's some linkage there between the 2.
Yeah. So, I mean, if you look at where they are inside your body, the bladder and the bowel are really right next to each other. So if we have stool that's getting kind of stuck in our colon and things start to expand, the colon can stretch out. Because it's right next to the bladder, when it stretches out, it pushes into that bladder wall, puts pressure onto that bladder. And the bladder is kind of like a balloon. So it stretches out when it fills up. And then that pressure against the sides of the wall, the sides of the balloon, are kind of what trigger our body of like, oh, I need to go to the bathroom. And then it has to contract when we empty. Those bladder wall kind of contracts to squeeze the pee out. So if we have something that's pushing into that bladder wall and kind of giving that sensation of, oh, I need to go to the bathroom, it can cause the bladder to leak when it's not necessarily full, or we don't want it to, because there's that pressure against the bladder. So it's kind of like squeezing into the bladder and pushing the pee out when we don't want it to come out.
So it could be like your kid went to the bathroom, and then like 30 minutes later in the car ride, and they're like, I need to go to the bathroom. You're like, we just went to the bathroom. Like, how are you not? Did you not go? You got to find a gas station again.
Yeah.
Pull over.
So it could be like they're not fully emptying, or because the poop is pushing on the bladder gets kind of irritable. So it's like you're getting all these mixed signals of my bladder is full when it's really not. It's that pressure from the poop in your colon that's telling your bladder that it feels full.
So you're recommending like at like age 3, kind of the 3 and 5 marker, like for bedwetting or being potty trained. If it's not going well, maybe it's time to look into what other factors could be bothering it. So it's not just going to go away on its own.
No, and I mean, I think there's some give and take to that, but I think, early intervention is always better. If you can help these kids before they really get like into 2nd grade, 3rd grade, and you're having those social, emotional things where they're being made fun of, or they want to have sleepovers and they're embarrassed because they still have to wear a pull-up. And especially some kids who are prolonged bedwetters, it's like a pull-up isn't enough. It's like they have a huge amount. And so they just really can't participate in those. They can't participate in those social things, or they're fearful and anxious about it when they don't need to be. So it's really, there's things we can start to work on early on. And again, with nighttime, there's other components of it. But
and I think about from an early intervention standpoint, it's good because patterns that are strengthened are the ones that are lasting. And so if you have a dysfunctional pattern and it's just kind of left to be on its own, you develop strategies that aren't the best strategies, and then you reinforce those instead of like getting to the heart of the matter, addressing that, and then reinforce the proper pattern.
Exactly.
Right. So if you're in like 2nd grade, I mean, hope is not all lost.
Right. No,
but
for
it
sure.
could take longer to solve that problem. And I know in a world like, I got children, I'm broke all the time. Right. It's like, oh my gosh, like how many treatments do we have to go through this? Like, what are we going to have to do now? But in reality, like you can shove the problem under the rug, but it's going to manifest itself somewhere. And it's usually probably bigger than what it would have been had you just maybe got in and got it addressed. And so I'm really big on early intervention. There's be a plug for that. Right? Like if you're seeing things aren't right, they're not right. Like don't ignore them.
They're not going to go away. They're going to impact that kid in the future.
And most of the time, at least in our field, they're just not that big of a deal sometimes, especially with like little ones. It's pretty quick. Like they can overcome a lot of things very quickly. So I'm a big fan of that. I guess at this point, I mean, we got so much more to talk about. But we're gonna in this session just talking about things that can go wrong, but stay tuned because we're going to talk about those interventions and things that can be done in order to make these things better. And I think you'll be really amazed at what can happen and just how simple it is. And I love it because it's such a small thing, but it just has such a big impact on someone's life. And yet the treatment can be relatively simple and just have a huge impact on their life. It empowers the kids. And I love that because I love seeing kids that are able to just be independent, right? That's what we look for as parents. We just want our kids to grow up. We want them to be independent. Life's got enough problems as it is. Layer on those physical challenges, which then become emotional, social challenges, and then we're off onto this thing. But I think next time we'd like to dive a little bit deeper into this dysfunction, as Kellie mentioned, talking about some of those components that go into potty training, like the sensory piece and why things aren't going the way they should be going. So we're going to talk about the mechanical piece, but then we're also going to talk about the sensory piece and how that can be helped along the way. So thanks for joining us. Hope you can tune in next time as we talk about more of the potty, all the pieces.
all the pieces.
Till next time.